Can you tell us why you're getting the Pioneering Spirit Award?
Well, it's basically linked to the work I've done developing the Critical Care Pain Observation Tool, or CPOT, to say it shorter. CPOT is a pain assessment tool for nonverbal critically ill patients. It includes different behaviors that the nurses can look at when they take care of their patients. These items include facial expression, so looking at the face reactions of their patients and looking if it's related to pain. So typically what we call a grimace will include the brow lowering, the eyes tightly closed, and also the cheek and the mouth contraction. So it's basically a general contraction of the face. We also look at body movements. So is the patient trying to reach the pain site or to remove a stimulus? We look also at muscle tension, so rigidity, and this is done by performing a passive flexion and extension of the patient's arm and to feel any resistance. The nurse who is moving the patient, like turning the patient in bed, can easily feel if the patient is tense or not. And we also have another item that we select based on the patient's condition. So we either use compliance with the ventilator, so if the patient is fighting the ventilator, for example, so this is for mechanically ventilated patients, but those who are not mechanically ventilated, we look for sounds. Moaning, verbal complaints of pain, or tearing. So we use in total 4 items, and the total score range from 0 to 8. And when the score is higher than 2, then we have enough evidence to support that the patient may be in pain and then to intervene accordingly, either by using a non-pharmacological intervention or a pharmacological intervention. Reassessment is extremely important. So we can use a CPOT to reassess pain and to assess the intervention effectiveness for pain management. When we use the pain for that purpose, then we aim to have a decrease in the score of at least 2 points.
How did you get into this type of research? What is your background that led you to want to know more about this?
Well, I'm an ICU nurse. Well, I've used to be at the bedside for many years. I got very frustrated not being able to provide appropriate pain management to my patients, especially those who could not speak for themselves. So we had, at the time, so it was before 2000, we had no tools available for pain assessment in patients unable to self-report. So we had to report our observations to the physician, and very often it was very difficult to have a response from a physician because we had no evidence-based tool to support our observations. And it was a discussion about, getting the right treatment for the patient. Was it pain or something else? So the need was there to have a tool to better assess patients. We had other tools at the time to assess sedation, but for pain at the time we had not much available. Now there's more and more tools available. CPOT is one of them. But this is really what motivated me to do something about it and maybe change practice.
So has this led more objectivity rather than subjectivity when people are trying to assess pain?
It's a very good question, and it's not clear-cut like objective versus subjective, because yes, we try as much as we can. Like in the CPOT, there are description of each item, which we try to make them as objective as possible. But I mean, there's always a subjectivity of the observer, the nurse, and how you perceive your patient. So I think we try to make this as objective as we can, but there's still, part of subjectivity based on the knowledge of the patient and the perception also as a caregiver.
How has this tool evolved since its inception?
Well, the content itself has not changed a lot, although we're doing work revising some sections, but the tool has been initially developed in French and then back translated into English And I know that it's been translated in many other languages. I would say 15 to 20 different languages around the world. So I think in terms of, the buy-in in the tool from the different countries is growing. And the tool is also being implemented into practice in many settings, especially in North America, but also elsewhere around the world. And in terms of its content itself, we've looked at more complex patients like those with a brain injury who will tend to have a severe injury and be more sedated or unconscious and heavily sedated. We found that the grimace that I described at the beginning was not as obvious in those patients. They also expressed different behaviors. Tearing, we tend to observe tearing more often in those patients. So we revised the content of the different items to make them fit better the brain-injured ICU patients. We've tested it, and we're now working on a paper on the validation of this revised version. So there would be the original CPOT that I talked to you about, and the revised CPOT Neuro that we decided to call it.
It's so widespread now. How are people learning about this?
So in terms of education, there is an online video that can be accessed for free. It's a bit less than 15 minutes. And in this video, the learners can see a description of the tool, and they also can practice using patient videos that are included, and a demonstration also with feedback. So they can have access to that. I have a lot of people who contact me to get directives of use, but they can easily find that information online as well.